Good afternoon. Vital signs. At the core of every physician encounter with a medical doctor is the assessment of vital signs, namely a patient's core body temperature, blood pressure, heart rate, and respiratory rate. How ironic then that although we choose to call these vital signs, that most patients have them assessed only on a twice-a-year basis, and we choose to make decisions about their health care based on those two spot checks for the remainder of the year. As problematic are those instances where patients come to us with a complaint or an ED or a symptom that's already occurred, and we take today's vital signs and try to guesstimate what the vital signs may have been when a patient suffered one of these symptomatic episodes. A classic example of having the wrong data at the wrong time. Let me take and focus on one of these vital signs, namely the heart rate, and by extension, the heart rhythm, because in 2014, this is the one of those four vital signs that we have the ability to monitor continuously and long-term. And let me do it in the context of two clinical diseases, namely syncope and atrial fibrillation, which affect millions of Americans and drain billions out of our healthcare system on an annual basis. If I took a show of hands and asked how many folks in the audience have had an episode of syncope or an episode of fainting, a lot of hands would go up. If I asked how many of you have had multiple episodes of syncope, a lot of hands go up. In fact, it should come, or it may come as some surprise to you, that this one entity alone accounts for 3% of all emergency room visits to the United States and 6% of all admissions to the United States hospitals. It's also been shown that once admitted, the average patient undergoes 13 diagnostic tests, and a quarter of the patients actually undergo 20 diagnostic tests. And despite that, 40% of people get discharged from the hospital with no specific diagnosis. Atrial fibrillation, a major risk factor for stroke, is on an epidemic rise in the United States based on the aging of our population, the obesity epidemic, and with the attendant increase in hypertension and diabetes. And it is all too common to see individuals present with their first manifestation as a devastating stroke, and when the underlying problem was atrial fibrillation, which had been undergoing for a long period of time. Let me take both of these diseases as an example of how diagnostic monitoring has fundamentally changed the way I'm able to deliver care to patients at risk with these diseases. And at the core of these diagnostic monitors are the advent of miniaturized technologies like these microchip implants that can be implanted analogous to what I tell my teenage daughters is a form of medical piercing, really no more difficult than getting their ears pierced at the average mall. This monitor has the ability to provide continuous ECG data on an individual for up to 3 years. How does it work? Every day, the EKG of a patient is accumulated, and when they go to bed at night, the information is transmitted to my office over the internet, and I am alerted when a patient has met a pre-programmed alert criteria. Let me show you the representative case of how such monitors can impact clinical care. So my patient is an 83-year-old female who presented 3.5 years ago after having an abrupt episode of fainting. As is typical, she was admitted, subject to a slew of diagnostic tests, and no etiology could be found. She did well until 2 years later when she had another fainting episode, and as is typical, the same process was repeated. Admission, repeated diagnostic tests, all non-diagnostic, and the patient was discharged to follow-up. When the patient had her third fainting episode 6 months later, she did not even bother seeking medical attention, knowing what she'd gone through the first 2 times, until the next morning when she woke up unable to speak. Fortunately, this episode resolved in an hour, which prompted her to seek medical attention. A CAT scan showed a clear evidence of a new stroke, but at that time, all of her vital signs were within normal limits, and no etiology could be identified, and the patient was labeled as having had a cryptogenic stroke. It is then that the patient was referred to me for further evaluation, and we made the decision to proceed directly with implantation of one of these monitors. Shown here is what was recorded from this monitor 4.5 months after device implantation, after she had now her 4th fainting episode. It's important to note that this interval between the implant of the diagnostic monitor and this episode is what makes it so difficult to hospitalize patients for a couple of days and get to the etiology of these symptoms. So shown in this slide on the top is her rhythm, which is an irregular rhythm which characterizes atrial fibrillation. Atrial fibrillation was the reason why she'd had her prior stroke. Because she had no symptoms referable to this atrial fibrillation, it had never been diagnosed. In this patient, when atrial fibrillation terminated, it terminated with missing heartbeats. And you see basically this patient flatlined for several seconds, during which she lost consciousness and had her characteristic fainting episode. Eventually, her heartbeat recovered and she regained consciousness and returned to her baseline state. So ladies and gentlemen, in this example, the stroke is no longer cryptogenic and the etiology for syncope is no longer a mystery. And I would argue to you that today, in 2014, this is what vital signs needs to be. Assess them when it counts, not simply when the patient is in the office. And hopefully, as the next frontier, when we have this meeting 4 or 5 years from now, it will be such that this is not the only vital sign that we're able to monitor continuously, but all 4 of our core vital signs will be available for continuous monitoring to help both physicians and patients get the maximal clinical benefit and solve these unneeded medical mysteries. Thank you very much.